It's an enormous pleasure to be here. I'd like to thank the Kirkbride Melanoma Centre for the invitation. And really, for me, it's really exciting to be standing before you because, you know, as a young researcher now, but 16 years ago, I joined the Peter MacCallum Cancer Centre and I didn't do any melanoma research at that point in time. And they said to me, well, would you like to take on melanoma? And, you know, I said to my boss at the time, well, it's a disease, sadly, where we don't have any effective drug treatments if the disease is spread. And I also said that it's a disease where, because it starts in the skin, we can observe it. It often spreads within the skin. We can do biopsies and study the science of the tissue, the melanoma tissue. And I thought, for a lab researcher, this is a wonderful opportunity because there's only one way to go, and that's to make improvements because we didn't have any effective therapies. And, you know, I stand before you this evening with a real sense of optimism that actually we're going to be able to reduce the mortality and the burden of this disease quite dramatically in Australia. So for me, it's just an enormous pleasure and privilege to be before you this evening. So I want to address the question, how can we reduce the mortality from melanoma in Australia? So what is melanoma? I mean, I think everyone in the room probably knows this very well, but we all have in our skin melanocytes, cells that make the pigment. This is the melanocytes in the basal bottom layer of our skin. They give our skin colour, and if you get the disease of vitiligo, so that the melanocytes disappear, this is what happens. You get these white patches because the melanocytes give us the colour and pigment in our skin, and if they become cancerous, that's the disease of melanoma. Now, what's very important, I think, about melanoma is that these cancerous cells have, unfortunately, an enormous capacity to spread. As I'll get to, 90% of melanoma can be cured with surgery, but melanomas are amongst the smallest cancers we diagnose in clinical medicine. They're very small tumours, but they have this capacity to move down through the skin and end up spreading via the bloodstream. And they do this when they're very small. And this is actually a really important point, and why a part of our strategy to reduce the burden and the mortality from melanoma has to be drugs. Treatments that can affect melanoma cells wherever they happen to spread, because they have this inherent capacity to be able to spread. So I think we all know this, but along with our close cousins in New Zealand, we have the highest rates of melanoma in the world. So here's a number of US and European countries. We have dramatically higher rates of melanoma in Australia. So many people say it's Australia's disease, and that's true. You know, why do we have such high rates? Well, we have a lot of, as I'll get to, UV radiation in our environment, and we have a lot of fair-skinned people in our country, which is a risk factor for melanoma, so that's why it's so high. Now, a few facts and figures. So, 1 in 18 Australians will get melanoma in their lifetime. Breast cancer is actually 1 in 16, of course very rare in men, but pretty similar overall to breast cancer. 1 in 14 males and 1 in 24 females, and I'll get to later the importance of melanoma in men, because this is, you know, really, I think, somewhat of an epidemic in our country that we need to deal with. 11,000 new cases a year. The figure that I think is very striking, if you think about, you know, the world population, 6.4% of global cases of melanoma in Australia. I mean, we're a very small population compared to the population might of India and China, and yet we have 6.4% of the cases. Most common cancer in 20 to 40-year-olds. 10% of all cancers in Australia are melanomas, again, pretty similar to breast cancer. And the death rates have not been reducing, which I'll get to as well, but I think we can be very hopeful now. So the good news I mentioned is that 90% of melanomas are cured by surgery if detected early. Okay, so that's the good news. And Australia has the best melanoma survival rates in the world. We have a good healthcare system, and we do have the best melanoma survival rates in the world. Now, overall with cancer, we've got really good news, I think, that compared to, when I was a youngster, the cancer mortality and death rates are substantially reducing. And this shows you by years the mortality from cancer for Australia in the red line and the US in the blue line. So, where the countries like the United States of America and Australia, we're reducing cancer mortality. So we're doing well. But we are not doing so well in melanoma. You can see it's sort of trending upwards very slightly in melanoma, which is quite different to lung cancer, where the rates have been reducing, principally with lung cancer due to reduction in tobacco consumption. And that's an important point because, cancers can be prevented. So how do we reduce mortality? So I think there's a triad, if you like, of approaches. One is prevention. One is early detection. This is perhaps fairly simple and obvious. I mean, melanomas start in virtually all cases, not all, but virtually all, on the skin. And we can observe the skin. We have the opportunity of detecting melanoma early. So we can detect it early, and as I'll get to, we know the causes of melanoma in the vast majority of cases, which is sunshine and UV radiation. And then down the bottom here of this triad is improved treatment, and that's where there's been dramatic improvements in treatments over the last particularly 5 to 6 years. And I think this is actually poised to add to these other strategies to achieve reductions in mortality and the burden of melanoma. So prevention. I think probably everyone in the room knows this, but our beautiful Australian sunshine does come with the price of UV radiation that mutates the DNA in the cells of our skin, and that's why we have such high rates of skin cancer and melanoma in Australia. And of course, solariums. And I was really delighted now that Western Australia is joining the rest of the country by banning solariums, and that's a fantastic step forward in preventing this disease. Probably solariums only contribute around 5% maximum of the caseload of melanoma in Australia, so not a big proportion, but absolutely preventable. And it's also sending a very important public health message. Solariums give UV radiation. It's like the sun. It reinforces to people the dangers of UV radiation. So it's great that we now are in sight of a national ban. Now, I mentioned Australia has beautiful sunshine. Well, it has a lot of UV radiation. So this is the UV radiation map for our country at midday today. So you can rank the level of UV radiation by the so-called UV index that you can read in the newspaper every day, and you can look at live on apps on your phone. Purple is extreme, very high UV radiation. 1 to 2 is low, where you don't need any protection against UV. And have a look at midday in our country today. Everywhere in mainland Australia is in the extreme range. Tasmania is in the very high range. We have intense UV radiation in this country, which, coupled with the fact we have many fair-skinned people, means why we have such high rates of melanoma. So we've got to recognise this fact. If we look at it across the time of the day, and again this is the UV map for time of day for Perth today, so extreme in the middle of the day, but the safe times in the green are in fact before 8:10 a.m. in the morning and after 4:10 in the afternoon. So a big part of the day this time of year is very high UV that can damage the DNA in our skin and cause skin cancers and melanoma. So these are the safe periods where, in fact, people often say, well, you need the sun for vitamin D. These are the periods where you can get out and get some UV, low-level UV exposure, safe for your skin, and produce vitamin D. Or you do like a guy like I do, which I work inside all day doing research, seeing patients, doing lectures, etc. So I don't get much sunshine. So what I do is I just take a vitamin D tablet every day to maintain my levels. And my GP did ask me to measure the levels. I said I'll be low for sure because I'm an indoors sort of worker, and sure enough I was low. So that's my personal strategy. So preventing melanoma, we've got to reduce this UV exposure, protect yourself in 5 ways. We know the Sun Smart messages. Very important, we've got to continue to do that. So how else are we going to reduce the mortality? So early detection is important. So there's been efforts to scientifically develop new strategies for early detection with sophisticated imaging techniques. There's a bit of evidence from Germany that actually going and seeing a dermatologist or primary care physician can reduce the mortality from melanoma. It's a little bit controversial, but there's some evidence that skin checks can reduce the mortality. But one of the things that's very, very, I think, useful in Australia, we have fantastic awareness now, and people are presenting when things are changing on their skin. Here's Scott, and the well-known figure promoting awareness in Western Australia, national advertising campaigns, and people like Claire Oliver, who, interestingly, when she went forward with her campaign about the dangers of solariums, 80% of Australians knew who Claire Oliver was, with some market research done a year or two later, and that was enormously helpful in raising the awareness of melanoma and to get people to get their skin checked. Now, I mentioned we've got a problem with men before, so this is Victorian data, but this is men on the left and women on the right, and this is caseloads of melanoma by age, over 70, 45 to 69, and here in the young. So in the young we're trending down in both men and women, which is because of that prevention strategies. But look what's happening in particularly older men and middle-aged men, but also women. You look at the scales here are different. You see 140 on the top here, 250 here, more of a problem in men. So we can't rely on prevention strategies for everyone because people, particularly older individuals, have already had a lot of UV exposure, so we need early detection, cut out early, and more effective treatments. Now, you know, there's a warning for men because it's not just that men are getting more melanoma, we've got a good idea why. They spend more time outside than women, particularly during the middle of the day. I've showed you the UV. Men actually use sun protection less than women. And men are less likely to go to their doctor. So we actually need some more early detection strategies and prevention strategies targeting men because men are not doing as well as women. All right, so early detection can help, and now I want to move to improve treatment for the remainder of the time. So there's a number of ways that we're improving treatment. One is multidisciplinary care. So in Western Australia there's a fantastic statewide multidisciplinary service for patients with a diagnosis of melanoma. Multiple specialists get together and discuss aspects of cases and come up with recommendations. We're starting to use technology, so you can sequence genomes now, so we can put melanoma genomes into sequencing machines and get a lot of information about all the damage that the UV has done to the melanoma. And what we find from that is that, first of all, that melanomas overall have 5 times more gene mutations than any other cancer, 4 times the number of mutations in the DNA compared to lung cancer, and 10 times compared to a disease like ovarian cancer. So there's a lot of gene mutations in melanoma. And one of these gene mutations, of course, you've all heard about, is BRAF. It turns on this gene, this encodes a protein that makes cells grow. So if you put them in the lab, you get little colonies of cells growing. But then if you turn off that BRAF protein with a target therapy, you can eradicate that. And that's obviously been, you know, a major step forward. Here's a patient. This is a PET scan, and this big black blob here, unfortunately, is the liver full of melanoma. This is the brain, this is the bladder, but that's the liver. And then after only 2 weeks of treatment with BRAF inhibitor, that has normalised quite a dramatic response. So we've got to do more research, and that's why the Kirkbride Melanoma Centre is so important, because BRAF treatment can stop working. Some people it keeps working, we've got to understand why, but in many people it does stop working, you need to go into other treatments. And so we need to research that, and one mechanism for that that's been identified is a thing called a RAS mutation. So the research is starting to tell us why things like BRAF can stop working. And we do get some long-term survival in patients with BRAF inhibitors. Not everyone progresses. So this is the very first trial we did, starting back in 2000 now and 8, and we have patients that are still alive doing well with BRAF inhibitors. Now the longest for me is a patient who's out to 6.5 years and doing extremely well. So some patients can do well on BRAF inhibitors, but this is what we call a survival curve, and it is only about 15 to 20% of patients that seem to fit into that category. So we need to do a lot more. I think Peter introduced the fact that melanoma has been a great space for innovation. So these are some of the world's top journals, like the New England Journal of Medicine and Nature, the Science Journal, and melanoma has been dominating these and is leading concepts in other areas of cancer. And as I'll get to, things like the BRAF, but also the new immune treatments are very important in driving these new innovations for us. So the immune treatments is, I think, what we're really excited about now, that we can unlock the body's own defences to kill melanoma. This is a T cell, a killer T cell attacking a tumour cell. And there's a prediction that within the next 2 years there'll be Nobel Prizes awarded for this discovery, because it has just completely transformed cancer. And what this is understanding there are things called checkpoints, and there's 2 checkpoints. There's one the drug Yervoy targets called CTLA-4, and what that does is it increases the number of killer T cells that can attack the tumour. But there's the discovery of another checkpoint that's called PD-1, which I'll get to in a moment. But first of all, I just want to show you an example of success with Yervoy. So this is one of my patients who was bedbound with very extensive melanoma. This is a PET scan. I've shown you this is the normal glucose on a PET scan in the brain and the heart and in the bladder. But this is all the bones for my patient. Unfortunately, Anna had a large amount of melanoma in her bones and was treated with Yervoy, and then after only 4 months, she'd had a complete response to Yervoy that targets this CTLA-4. And here's Anna. 6 weeks ago, just rode over 200 kilometres in 2 days for the Ride to Conquer Cancer in Melbourne, and I was very privileged to be able to cross the finish line with her. And given that she was bedbound with melanoma eroding her bones, to see her now doing so well and able to do this 3.5 years later is really quite remarkable. It shows you the power of the immune system. You can get these very long-lasting responses, and maybe Michael will, perhaps following me, will talk about it, maybe cures for some patients. So these immune checkpoint antibodies, they can even work in brain disease. People said, oh no, the immune system will never work for brain disease, but it can. It can work when there's big cancer lumps as well. It might work better when they're small. Most cancer treatments work better when they're small. But these immune checkpoint antibodies are have really turned us around the way we're dealing with things. What we know is going out to now 10 years is that if you get a response to one of these anti-CTLA-4 Yervoy treatments, that it can last a very long time, and that's why we're wondering that some patients may effectively be cured with these treatments. So the other checkpoint we've all heard about is PD-1. It's different. It doesn't increase the number of the killer T cells. What it does is it unmasks the clever tumour cells that turn off the T cells by this molecule called PD-L1. It turns that off so that the tumour cell can now be seen by the T cell, the killer T cell, and attack it. And we get very long-lasting responses to PD-1. So this is patients treated with PD-1 out now here to about 4 years. Very durable responses, seem to be better so far than what we see with the targeted therapies, but not all patients respond to these checkpoint inhibitors. Virtually all patients respond to targeted treatments like the BRAF, but not all respond to the immune checkpoint inhibitors because, unfortunately, this is the survival if you don't respond to PD-1. So, yes, it's a breakthrough, but not for all patients, and that's why we need to stop rolling the dice and hope that the numbers will come up and people will respond to PD-1. We've got to turn that into a targeted approach so that we know who's going to respond, and we need more research like is happening at the Kirkbride Melanoma Centre. Sort of things we're looking at is we're looking at all these different immune cells inside a tumour and trying to work out if we can predict who's going to respond to that. And we're doing all this DNA sequencing as well, which one can do to try to understand who's going to respond. But we must find out why some people respond well and why others do not with these immune treatments. There's a lot of other immune treatments coming. This is very complex stuff, lots of different types of cells, lots of molecules. There's a flurry on of the discovery of new PD-1 and Yervoy CTLA-4-like drugs. And so we're going to see a lot of new treatments moving forward to activate the immune system. And particularly one is to put these two things together, CTLA-4 and PD-1. And some of the most exciting data that we have at the moment in melanoma is the survival when you put PD-1 together with CTLA-4, and that's actually before the PBS at the moment for consideration for funding in Australia of putting those two together. So we've got, as the economists put it, a fifth way to fight cancer now, which is the immune system attacking the tumour cells. We've now unlocked this. I think there will be a Nobel Prize within the next couple of years for this discovery. It's so fundamental to our fight against cancer. And these drug treatments, I think, because of that capacity of the melanoma cells to spread, are going to contribute to our ability of reducing the mortality from melanoma. So we've got to do this as a team, and that means all of you, the community, scientists like people at the Perkins and the Kirkbride Melanoma Centre. We must work with industry that can develop and do the clinical trials for these new drugs, and our government need to support us all with access to drugs and continue to invest in medical research. And through that, hopefully, we can get a lot more people like Anna that can have their lives turned around from this insidious disease of melanoma. And putting everything together, prevention, early detection and the new treatments, we need to get that mortality for melanoma down like lung cancer has occurred, and I would hope that we can even reduce mortality in the next 15 years by about 50% with these sort of strategies. So thank you very much, and I'll hand back to Peter.
Thanks, Peter, and thanks for asking me to come here, and thanks to all of you for coming along and hopefully learning more about melanoma and where we're going. It's a really exciting time. One of the legacies from my time in Peter MacCallum is that I look at the Age online every morning to see the news in Melbourne. So I was fascinated to see in Melbourne it was announced that an eminent professor would be talking about a new theory of cancer at 5:30 p.m. at the Perkins Centre. And I thought, well, that's pretty good if we've reached out to Melbourne. And it was when I got into the story that it was in fact Professor Paul Davis, who's an evolutionary biologist and physicist who has a novel theory about the way we get cancer and how to treat it, and he's speaking at the Charles Perkins Centre at the University of New South Wales. And you're not too late, it's tomorrow, not today. But if any of you here are expecting to listen to him, I'm sorry to disappoint you. So I'm going to focus a little bit more on the local scene and the importance of clinical trials so patients in Western Australia can gain access to these new promising treatments. And this is our sort of local data from 2013. We have about 1,200 cases of melanoma in WA. We had about 158 deaths from melanoma. Melanoma is a leading cause of cancer deaths, particularly in men, as Grant said, but also in women. But as we know, melanoma is not just a disease of the elderly, like other cancers, but melanoma deaths disproportionately occur in younger patients. And if you look at the economic life years lost to the country because of cancer death, melanoma is substantially over-represented. So we've gone a long way even in a year. And this is a slide I showed at one of these forums 12 months ago, just to look at some of these new treatments. The top three are the BRAF inhibitors, and the bottom three are the immune drugs, the checkpoint inhibitors. And we had some that were approved for use in Australia, but not all of them were funded. Some were available on an access program, but not all of them. And right now, we're a lot better off than we were 12 months ago. Only one drug, the top one, is really fallen out of use in Australia, and that's not a disaster because the second one's just as good. So we now have fairly universal availability of both BRAF inhibitors and at least two immune therapies. And there are others that have been submitted that are available on access programs. And another interesting one coming along, which is actually a modified viral drug given by injection into tumours, so it's only applicable to a small number of patients, but that's something that may come into more use over the next few years. I'm just going to spend a few minutes talking about one of the first things that the Scott Kirkbride Centre funded, which was the WA Melanoma Health Study. And this is not about treatment for melanoma, but it's about collecting data and samples from patients, and I'm sure some of you or your relatives contributed to this study to try and look at prediction and risk factors for melanoma. And the only way you can do this is to collect data and to collect blood samples from large numbers of people diagnosed with melanoma. So we recruited people who we knew had melanoma through the WA Cancer Registry, and we collected this data from collected these patients from January 2006 to September 2009. And we collected questionnaires, so some of these patients came and were interviewed, and some were interviewed over the phone, and some were both. And we had quite a lot of detailed questions that were asked about these people and their family history, lifestyle characteristics, sun exposure, etc., etc. And we collected a lot of data about their melanoma from the Cancer Registry pathology records, and we collected blood samples to collect and store their DNA and other genetic information. And we had 1,200 plus patients who agreed to do this, which is a fantastic effort. Because most places that have done this around the world, they've sort of collected people who've come to a specific centre or been identified at high risk or already known to have a family history. It's very much harder to do this, try and collect everybody who's diagnosed in a particular period of time. This was predominantly led by Sarah Ward. I don't know if Sarah's here. She was here earlier today. And she's put an enormous amount of time and effort into setting all this up and collecting everything. And this is now a resource that can be used and combined with similar resources in Queensland, in the UK, in the United States, to build up the numbers of people where we can look at why people develop melanoma, why some people do badly, and do other projects. And this is just one of them, looking at the factors involved in what your scar looks like after you've had surgery for melanoma. So when I started doing melanoma, and this was some time ago, we had a sort of situation where your only real hope to get any sort of improvement in your melanoma if it was advanced and it spread would be to go on a clinical trial, because the existing treatments we had were very, very rarely effective. So if you went on a trial and could get access to a trial, you were going to do well, hopefully, because the treatments that were available to you outside a trial were not going to be very effective. So when I came back here, which was 12 years ago now, Peter, not 15, but 12 years ago, there were a lot of ideas going around about clinical trials and new drugs, but most of them, in fact all of them, really had very little effect. And then we entered this transition point, about 2006, 2007, where we started to see drugs coming along that really could impact on patients with melanoma. And these are the ones that we've used here in clinical trials, these immune drugs that Grant's mentioned, the BRAF inhibiting drugs, and because of this, we now have these patients with advanced melanoma who have been alive for a long, long time. So we have patients still alive who received one of the original immune checkpoint inhibitors back in 2007, 2008. We have lots of patients who received ipilimumab because not only did we have that on clinical trials, we subsequently had that on access programs before it was generally available. We have patients still alive from the initial studies of dabrafenib, the BRAF inhibitor. And we have patients still alive from the initial studies of vemurafenib. And I'm not sure we can talk about cure yet, but these people are in remission in that they've had complete response of their melanoma. We can't find it on scans anymore, and they're feeling well and doing fine. And we hope that will last. We have a lot more patients doing well on the BRAF combination, which is now in routine clinical use and has really transformed treatment of patients with BRAF melanoma. And we have patients doing very well on the PD-1 inhibitor pembrolizumab, and again, people who are getting out to some years on treatment, disease not apparent on scans, in remission. And that number will grow all the time because, again, we were able to get the drug not just for clinical trials, but on an access program before it was available generally. This is a slide that I presented in 2002. That's a long time ago now. I wasn't even back in Perth then. I was working in Sydney, and one of my jobs was to try and encourage clinical trials to come to Sydney. And I sort of put this slide up to sort of try and list the issues that we had, in the Australian context of trying to get clinical trials to Australia. And I sort of listed these more or less. I'm sure there are more, but these things struck out. Developing new cancer drugs is a global enterprise. It's a global enterprise, and we're a small country, and we didn't then, and we still don't, have enough oncologists to service our population. We're geographically isolated in Australia. The leading companies developing drugs are generally based in the US or Europe or both, and Australia's a long way away, and there are much bigger countries that they're headquartered in or close to them where they can recruit patients and do their trials. We don't have a particularly good national research infrastructure funding, particularly to support clinical trials, and we don't have very massive institutions, although we've certainly improved since 2002. And we don't have a lot of discovery of new drugs in Australia. So it's hard to get drugs into our early clinical trials unless we have a reason to do so. And one of the good reasons is if those drugs are actually discovered or developed locally. And this is part of a review I did a few years ago looking at clinical trials in an area outside melanoma. But just some of the problems that developed, this was about 2012. There were difficulties around the country with getting ethics approval for trials. There were difficulties funding clinical trials outside of the pharmaceutical industry. There was more risk aversion, so institutions were less likely to approve clinical trials being done. And we still had fragmented things like state-based requirements that hindered national approaches. So a couple of years ago, and some of you might have been there, I gave a talk at the State Cancer Conference that the Cancer Council put on. And I sort of updated that initial slide from 2002 to try and change it into a Western Australian format in 2013 and look at some of the problems we now have in Western Australia to try and attract clinical trials of these exciting drugs here. And everything that's true about Australia is true about Western Australia in the Australian context. We have a small population. We're geographically isolated from the rest of Australia. We don't have an infrastructure funding or trials infrastructure. We don't have critical mass, and we have very, very few potential discoveries here. So all the issues that made it hard in an Australian context make it very hard in a West Australian context. And so this is one of the slides I showed then, just an email that had come across my desk earlier that week, asking if we could do, or interest in a clinical trial. A review has identified Charles Gairdner as one of 10 sites we'd like to work with to open this clinical trial. Currently in the eastern states we can do all this in one go. Western Australia won't agree to this approach. So this is some of the challenges I listed then, and this is becoming increasingly important. How can we here ensure that we can attract clinical trials of promising treatments? How do we ensure that we can access as many, we can offer clinical trials to as many patients as possible? Some things we can do and some things we can't do. We can't become 10 times bigger. We can't have 10 times the number of oncologists. We can't have headquarters of international pharmaceutical companies. We can't suddenly develop lots and lots of drugs locally. We can't overcome those barriers, but there are some things that we can do. We can become very innovative in how we approve and set up clinical trials. We can work together a lot more than we do. So where are we now? Well, we've probably gone backwards since 2013. We've had a number of trials in melanoma that are not being done in Western Australia, but are only being done in sites in the eastern states. We're starting to fragment our cancer care delivery rather than coordinate it and build it. We've not had any reform in the clinical trials approval processes that were identified several years ago. And we're unfortunately getting under more and more pressure in our tertiary academic hospitals to become less focused on developing research and doing clinical trials and engaging in academic teaching and research activity. And this is under particular threat at the moment as we face significant cutbacks in health. So I have concerns that we will continue to do as well as we have, that patients in Western Australia will be able to access novel treatments, and that the advances that will come will be available to us only at later stages than elsewhere in the country. I had an interesting conversation a while ago with someone from industry, and I sort of said, well, you know, it's not really very fair for patients in Perth if there's nowhere in Western Australia that is doing this trial. And he said, oh, that's not a problem, just send them to Sydney. And I said, well, you know, in your context, that's like telling someone in London to go to Athens for a clinical trial. And they had no idea. They sort of assumed, you know, it was as easy as going from London to Birmingham or Birmingham to Newcastle in the UK. So unless we can get clinical trials here, we don't have an option like in other countries of saying, you know, go somewhere else, because the next somewhere else is thousands of kilometres away. Thank you.